You can go, Amali. Dr. Mhlongo, you can go on.
Good afternoon, ladies and gentlemen. And we are welcoming you to our nursing discipline webinar entitled Working on the Front Lines, the Impact of COVID-19 on Nursing Staff and Students. We thank you for making time to attend this webinar. And we are very fortunate to have speakers who are nurses to share their experiences in the midst of the pandemic, COVID-19. In the interest of time, I would request our participants to check the bio sketches of the speakers from the invitation that was sent out. Right now, I would like to acknowledge the presence of our acting dean, Professor Anna Voce, and I would like to start by having opening remarks by her, Professor Anna Voce, who is the acting dean and the head of school in the School of Nursing and Public Health. Over to you, Professor Voce. I'm getting a message from our college public relations that we need to wait for a minute for people to come in. In the meantime, while I'm waiting for some of the participants, I would like to introduce myself. I'm Dr. Mbalim Shongo, and I'll be facilitating this webinar. I'm a senior lecturer in the nursing discipline in the same school as our dean, the School of Nursing and Public Health. We are going to wait a few seconds as instructed by our college public relations officer. We'll wait for a few seconds and then we'll continue with the opening address by the dean. Thank you, Prof. Voce. I can see you've joined in. Thank you for blessing us with your presence. And we'll just wait for a go-ahead from Nombuso, from the college PR office. Thank you. The PR office have given us a go-ahead. At this point, I would like to hand over to Professor Voce to give us the opening remarks. Thank you, Anna.
Thank you. It's a pleasure to be here, and thank you, Dr. Mhlongo, for your introduction and for your invitation to make some opening remarks for this important webinar. The Nurses' Pledge emphasizes several important principles, among which are leading by example, devotion, faithfulness, and responsibility. And at each stage of the pandemic, nurses at the front lines have indeed responded, not by just enacting these principles, but by embodying them. By the very nature of their profession, nurses were, and indeed are, at the front lines, responding unreservedly to the call of duty within a context of fear and anxiety in the face of a very real existential and occupational risk to themselves and by extension to their families, of having to very rapidly implement new clinical guidelines while observing very stringent infection prevention control measures in what is an ill-prepared health system, generally not well equipped, and whose weaknesses were laid bare by the healthcare demands of the pandemic. I think this webinar will give expression to some of the narratives of nurses at the front lines, demonstrating their resilience. I did read an article in the Daily Maverick on the weekend in which a journalist was stating, in the light of the traumatic events of last week, that she's tired of the defining feature of our national character being resilience. However, if important aspects of resilience are a sense of purpose and relational connectedness and mindfulness and self-awareness and self-care, we do need to analyze the narratives of nurses at the front line in a time of COVID to learn what we need to do post-pandemic to strengthen resilience, so that when another emergency hits, and it will no doubt hit us, we are not responding from a position of burnout and energy depletion, but from a position of strength and positive energy. Some years ago, I was involved in a program called Wellness for Effective Leadership, aimed at health workers generally, but the majority of participants were indeed nurses. And its aim was precisely to build the resilience of health workers. Also years ago, Sharon Fan from the School of Public Health at Wits University was involved in an initiative called Caring for the Carers. I do believe that initiatives like these need to be institutionalized in our health system to support health workers in non-emergency times and to help build preparedness for times of emergency. I don't want to end the opening of this webinar without extending my personal appreciation and a collective appreciation on behalf of the School of Nursing and Public Health for how nurses have stepped up and have served individual patients, the health system, and indeed the country. So thank you for hosting this webinar, and I hope all participants will indeed enjoy the webinar. Thank you.
Thank you so much, Prof. Voce, for these opening remarks. And as I said initially, we are so blessed that we have your presence here, and you've just touched some of the important things that nurses go through during this period. And you also touched on the important things about the nurses' pledge. We appreciate that, Prof. Voce. Before I move on to the official welcoming by our academic leader, may I please request participants to mute themselves, and secondly, to switch off their videos to improve the bandwidth. Thank you. The speakers will only open the videos when they are presenting. Thank you for your cooperation. Now, I would like to hand over to the academic leader of the nursing discipline, Professor Fikile Mtshali, to give us the official welcoming and the introductory remarks. Thank you, Prof. Mtshali.
Thank you very much, Dr. Mhlongo, for the good welcome and a warm welcome to the webinar. And thank you very much to our Dean for gracing us with her presence. I would like to thank all of the participants or attendees for joining us as we celebrate or honor the nursing staff and nursing students who are part of the frontline workers in the fight against COVID-19. So I would like to welcome you to this webinar, and I hope you are going to have a good time and be active in contributing towards the discussions that will be held later on. May I please switch off my camera because of the Wi-Fi connectivity problem this side? Is that fine, Dr.
You're
Mhlongo?
welcome. You're welcome, Prof. Mtshali. Go ahead. Thank you.
Thank you. All right, thank you. Today we are here. Today we are here to reflect the experience of nurses and nursing students are part of the workers in the fight against COVID-19. The year 2020 was dedicated by WHO as the year of the nurse and midwife. How can you hear me now?
Yeah, your
Okay,
connectivity is a bit poor, Prof. Mchali.
All right.
You are breaking sometimes.
Okay, so I was still saying 2020 was the year of the nurse, but unfortunately it was then overtaken by the unprecedented global challenge of COVID-19. This pandemic severely impacted health systems and health workforce, as well as populations accessing health services. The fight against COVID-19 has been a workforce-intensive effort. The pandemic reinforced the universal truth of no health without a workforce. It strengthened the global call to protect and invest in health workforce. The need was great in the African region, as the dean indicated, because of the constraint and underfunded healthcare system, which major outbreaks. According to WHO, as of 23rd May 2021, cumulatively, there were about 112,206 COVID-19 infections reported among healthcare workers in the region, with South Africa accounting for about 50% of these cases. In August 2020, South Africa accounted for 62% of infected health workers, with nurses accounting for 14,143 confirmed cases, that is 52%, and 6% were doctors. The recovery rate then among healthcare workers was reported at 58%.
Sorry, go ahead, Prof. Mchali. Sorry for the interruption.
Nursing and midwifery respond. I was saying, how did then the nursing and midwifery workforce respond to the COVID-19 pandemic? The first step was mobilizing additional nursing and midwifery workforce. The Department of Health at national and provincial levels, working with nursing directorates, had to conduct capacity assessments to establish available nursing and midwifery workforce to deal with the pandemic. The exercise included assessing the needed additional workforce to be placed in newly established COVID-19 dedicated facilities. The government recruited 13,135 unemployed and retired nurses just for the duration of the pandemic. And to facilitate the process, the Nursing Council then had to waiver the restoration fee for these nurses. And in addition, as an incentive to all the nurses, in the subscriptions for the year, for the next payment cycle, that is 2020 to 2021, the Nursing Council resolved that there won't be any increase. So we really appreciate that from the Nursing Council. Then the exercise of recruiting more nurses paid off because the research by Okelem that was done at the end of 2020 revealed that increasing the number of nursing and midwifery workforce in sub-Saharan Africa decreased the risk of COVID-19 deaths. The pandemic led to abrupt interruptions of teaching and learning and the delivery of some services, and we'll hear more about that from the speakers. I just want to point out that ICT, online learning platforms and mobile technologies became a lifeline during the pandemic, with nurses and other health workers placed in remote areas, utilizing mobile technologies to reach out to patients, to access current information and best practice guidelines on dealing with the pandemic. Then research on nursing and midwifery conducted last year and the beginning of this year revealed a number of issues that we'll learn about from our colleagues. Just to cite a few, the pandemic illuminated the role or the important role of community health nurses in fighting outbreaks at community level in a healthcare system that is based on a primary health care approach. And unfortunately, because these nurses, they don't qualify for OSD, then we are losing the number of nurses who are interested in community health nursing. The pandemic exposed nurses to situations that threatened their moral values. They were exposed to the risk of infection in the context of limited PPEs, and few studies revealed this as the most traumatic experience that led to threats of strikes in a number of countries. Nurses had to deal with stigmatization by the community and other health workers who were not placed in units dealing with COVID-19 patients. They had to continue serving in grossly understaffed health facilities. They had no time to mourn the loss of their colleagues. They had to work long hours while dealing with mental fatigue that affected their concentration. They had to deal with difficult triage decisions in the context where lack of definitive treatment for affected patient was not, there was lack of definitive treatment for affected patients. They had to deal with the feelings of hopelessness, especially in cases where the do not resuscitate policy applied. They had to deal with the pain and psychological trauma of losing large numbers of patients under their care. These experiences challenged their professional conduct and moral values. Unfortunately, our ethical codes do not provide clear guidance regarding what to do when confronted with life-threatening public emergencies in the context of limited resources. The pandemic exposed a number of areas that require urgent attention from nursing. The need to revisit the role of public health nursing in the fight against COVID-19, the issue of aging nursing and midwifery workforce, the need to invest in ICT infrastructure to support nursing education and practice, especially practice in remote areas. And then it also strengthened the need to migrate nursing education programs away from the Ministry of Health to be part of the post-secondary education or higher education. So for the students, all the nursing students, to fully benefit from the DHEAD resources that were available as part of the emergency response. So today we've met to come together and then recognize or pay tribute to all the health workers, especially the nurses and nursing students who continue to be at the forefront of the fight against nurses. We want to say thank you, colleagues, and we salute you. And I would like to extend my warm welcome, and I wish that you can enjoy this webinar and contribute as well to the discussions. Thank you very much.
Thank you very much, Professor Mchali, the academic leader of the nursing discipline. We thank you for those introductory remarks and the warm welcoming of our participants. Thank you. We're gonna move on with our program in the interest of time, and I would like to call our next speakers, that is Doctors M.A. Jarvis and Dr. Baloyi, O.B. Baloyi. They are both the senior lecturers in the nursing discipline. Dr. Jarvis is a mental health specialist and Dr. Baloyi is a midwifery specialist. They are going to be the next speakers, sharing experiences on the final year nursing students returning to clinical practice in the midst of the pandemic. Over to you, my fellow colleagues. Thank you.
Thank you, Dr. Mhlongo. In the interest of bandwidth, would you be okay if I switched off my video? So thank you, Dr. Mhlongo, and thank you to the participants who've joined us for this webinar. We are going to present We Didn't Know What to Expect. Final year nursing students returning to the clinical in the pandemic. This was a collaborative study between two universities. The background to the study is on the 17th of March 2020, the Minister of Higher Education declared that tertiary institutions were to close for an early recess. The students left campus, they left their residences, and they returned to their homes. On the 26th of May 2020, the Minister of Higher Education declared that from the 1st of June 2020, there would be a gradual controlled return of the tertiary institution students, including nurses. However, the students returned against the backdrop of a fourfold crisis in South Africa. Amongst this was the COVID-19 with its consequences, one of them exposing the inequalities amongst the students. Coupled with this was the higher education's commitment that no student should be left behind. We capitalized on this, and we added to that no student should be restricted, or there should be a handbrake on their progress and their ability to move forward because of psychological restraints. Adding to the pressure for the students was that the South African Nursing Council required that all requirements be met for completion. However, amongst this, there was light and hope as the advocacy by the WHO for mental health programs. The motivation behind our program was that despite the preparation for students' physical safety against the SARS-CoV-2, the psychological component was given lesser attention. There were mental health concerns associated with COVID-19, fear, anxiety, depression, and suicide. Added to that, compared to other healthcare workers, there's a higher psychological distress for COVID-19 amongst nurses. In addition, a Chinese study showed that the younger age and the higher education was associated with higher coronavirus anxiety. What we did work on was that when there was concern about COVID-19, there was increased motivation to perform preventative behaviors. So that had resulted us in embarking on a two-part study. It was a multi-method study, and I'm not going to go into the aspects what we focused on, but they're there on the slide for you to see. The focus of this particular presentation is so that you can have a take-home practical aspect, and the focus is on the outline of our digital psychological first aid intervention that we named mCOVID. We took an acronym of COVID and we added positive aspects to it that aligned with the digital psychological first aid. So it was connect, optimize, validate, inspire, de-stress. We created a logo, and that logo was carried through on our WhatsApp group display pictures as well. We're just going to give a very brief information with regards to the key quantitative results, and then very brief with regards to the qualitative results, and then the conclusion. So our population that we addressed at both universities was all final year nursing students returning to clinical settings, because we were both in hotspots at the time, and we both had the same group of students that were returning. So we designed an Mhealth digital intervention. It was developed through workshops with specialists. These specialists were Mhealth specialists. They were mental health specialists, IT specialists, and clinical specialists as well. It was two parts. Part A was a 3-session orientation, pre-placement, back to the allocated sites, and it was a test post completion of the sessions on the material that was completed with a pass rate of 80% as being acceptable. It ran between the 22nd to the 24th of July, and we ran it through Zoom. And you will see in the square brackets in red, I have outlined what was part of our particular program, the key factors, but also at the same time how they align with the psychological first aid concepts. So the first session, we looked at enhancing self-efficacy, and there was the development of competency in the use of PPE. Then we looked at the de-stress component, and we looked at theories of stress management strategies to manage the COVID-related stress. And the idea there was to focus on creating calm. We looked at information on the virus, epidemiology, and nursing care. And here this was for a sense of safety, and we brought in the optimize. The part B part of our program was a 4-week digital psychological first aid package that ran from the end of July to the end of August 2020, and we used the platforms of WhatsApp and Zoom. The preparation that we did was WhatsApp groups were created in the different universities, and the students were all provided with WhatsApp guidelines and WhatsApp etiquette. The program structure ran on the same rotational basis over the 4-week period, where we were looking at instilling hope, inspiring them through sending inspirational messages. We were looking at de-stressing, and in the de-stressing, it was creating calm, and the strategies that we sent was short audio clips where they could play these in the unit setting when they found themselves becoming particularly tense, and it would trust that it would allow them to relax. Linking with support, we linked with them through Zoom once a week, and we were available to chat about things and to offer support. Then we also provided knowledge on local and national COVID statistics once a week, and we provided them amongst all the tsunami of information that was out there. We selected what we believed to be recent, relevant COVID evidence-based information that could assist them. This is an example of one of the infograms that we sent out. This was University Pacific. The other one was also Pacific to the particular university. This is just a collage of an example of the inspirational messages that we sent out, some of the evidence-based information, some of the practical information to assist. I'm not going to go because the focus of here is not for our methodology, but just to let you know there was a quantitative component and there was a qualitative, which involved questionnaires, and it also involved 5 focus groups, which were then analyzed within the frame of Lazarus and Falcon stress appraisal model. The demographics for your information. And then the results from the qualitative part of the study is you can see that the primary appraisal initially was one with regards to anticipation of returning there. There were such extracts that people spoke about shivering at some point, getting hot. Even my gut, when I think about going to the clinical areas, I was anxious. And then as we moved through, they reappraised the situation. And we have such aspects and such extracts as information I get from my facilitators prepared me to go to the hospital, so it helped me a lot. In the quantitative aspect, we saw for the generalized anxiety, there was a significant decrease in the generalized anxiety compared to before the intervention. COVID fear also had a significant decrease. The sources of the COVID stress scale, we saw some changes, but not all completely changed. The highest stresses remained before and after, and those were related to their load of the university work and with regards to completing their hours. We saw decrease in all the other stresses, except there was an increase in the stress with regards to being able to access appropriate PPE, and then uncertainty if the institution will care for them if they became infected. So what is the take-home message from this? The take-home is that digital psychological first aid delivered through WhatsApp is effective. Students transitioning to an unfamiliar setting require knowledge, development of competency, hope, support, and encouragement. Academia needs to give recognition to the psychological aspect of students transitioning to unfamiliar settings. Thank you, Dr. Mhlongo.
Thank you, Dr. Jarvis. What an informative presentation. Besides the take-home message, my take-home message is the infographic and the collage, which I think students from all nursing education institutions may benefit from. Thank you, Dr. Jarvis, and thank you, Dr. Baloyi. We are going to move on in the interest of time and continue with our program. Our next speaker will be sharing some lessons learned in the primary care setting during the pandemic, and that is Dr. Themba Nxumalo. Over to you, Doc.
Good afternoon, everybody. Thank you so much to Dr. Mhlongo, and thank you to the previous speakers. As previously mentioned, my name is Dr. Themba Nxumalo. I don't want to go over my bio because I'm sure you've read that, but as you can see, I'm still a practicing clinician working at Ndodo Community Health Center in the Ilambe district. I'm mainly involved in the primary healthcare setting with integrated clinical services management in terms of non-communicable diseases such as TB, such as hypertension, diabetes, TB, HIV. So on a day-to-day basis, I'm mainly involved with HIV and HIV management. So as you can see, I don't have a slide, unfortunately, but I will be talking from my experiences working during COVID-19 in the primary healthcare setting and some of the strategies that we adopted in response to the COVID-19 pandemic. So before I go on, I would like to say that sincere apologies again for not having a slide, but I wanted to sort of give a real world feel of what COVID-19 was like from someone who's a clinician and who's practicing as a clinician at the moment within the primary healthcare context. I hope you can understand that. So I think we all remember that COVID-19, we had heard about COVID-19, I think towards the end of 2019, November, December, we had heard that it was a type of pneumonia-like illness that originated in Wuhan, China, and was spreading rapidly across the world and infecting numerous healthcare workers and the population in general. And then towards the early, if I don't remember, early parts of the year in 2020, it started spreading to other countries. And we've seen countries like Italy, how the health system crumbled as a result of COVID-19. So I think as an individual who was a clinician working within a primary healthcare context, we were suspecting that something like this was eventually going to come to South Africa. And in response to that, the Department of Health started sending us circulars to tell us that we should prepare ourselves because there's a pandemic that has originated in China that is rapidly spreading across the world, and we should prepare for it. But during the process, when the department was sending these circulars, the how part of the preparation was what was lacking. So we were told, circulars came out, we were told prepare, but we were not told to prepare how to prepare, So the information was very vague that was given to us. And then fast forward in March, there was case 0 in South Africa. And then after that, the numbers just started spreading and spreading and spreading. And because of the information that we had received from the media and from social media, the immediate thing amongst the people that I was working with, and even amongst myself, was, oh my God, we are not going to cope, especially because of the information that was circulating in social media of what was happening in Italy, what was happening in other first world countries like America. We thought, okay, so it's done. Like, this thing is coming to finish us. So there was a lot of anxiety and there was a lot of fear of the unknown. And that was stemming from, as I mentioned, from media and from social media. But also media and social media was a double-edged sword in the sense that because initially we had no information about how to manage this patient and how to prepare for COVID-19 outbreak in South Africa, I think the most healthcare workers, especially in the setting that I'm in, turned to media and social media to educate themselves. But as I mentioned before, that it was a double-edged sword in the sense that it also, the information that they received from media and the social media invoked feelings of anxiety, feelings of depression, feelings of fear, which most healthcare workers had. And at the same time, it was information that educated them about how to prepare themselves, because from the department, there was nothing that was preparing us to work as clinicians. If you look at when the guidelines came out for the primary healthcare context, it was, I think, around May, June. And then the pandemic has started in March. And then you ask yourself, as an independent practitioner working in a primary healthcare setting, a nurse is expected to work alone. So what is guiding the nurse between March and May, from the time that the guidelines came out? Because the only guidance that was there between March and April, and even now, was from the National Institute of Communicable Diseases. And that guideline that came out was not really explicit in terms of how you should manage a patient who is a PUI, that is a patient under investigation, one that is suspected to have COVID-19 and one that already has this COVID-19, especially within the primary healthcare context. So in that regard, I feel like there was poor preparation from the side of the government to prepare the workforce for the pandemic, especially because we had already seen what was happening in other countries in the beginning of the year. So also, the primary healthcare facility, in fact, most primary healthcare facilities that I know of and that I've been exposed to and that I'm working in right now, are not structured to meet the needs of, or the demands of COVID-19, in terms of isolation, in terms of management of the patient, and in terms of infection prevention and control. I mean, we have our standard precautions, which are the PPE, which is the ventilation, but the facilities didn't allow for one, social distancing. The infrastructure was too small. So we had to sort of improvise and think on our feet on what to do. In that regard, to implement social distancing, we had to now start seeing patients from the outside, which also created numerous other problems in terms of the quality of care rendered, and in terms of the fact that when weather conditions change, you know, it's difficult to now start nursing patients who are outside the clinic, because we cannot accommodate everyone within the clinic, because there's this new social distancing that needs to be implemented, because COVID-19 demands that, so that we reduce the spread of infections. Number two, the facility. Okay, at primary healthcare level, we were having patients who were presenting with symptoms, and we had this guideline which had a screening tool with which we'd use to screen patients when they come in the gates, and automatically, when a patient has one or more of those symptoms, was classified as a PUI, a patient under investigation, who needed to do a COVID test and then also be nursed in isolation up until it is confirmed whether the patient has or does not have COVID-19. So at a primary healthcare level, the traditional primary healthcare facilities do not have specialized isolation wards or isolation places where patients could be nursed. So also in that regard, it was the nurses or us who had to think about what to do to isolate that patient and prevent that person from potentially infecting other patients. So one of the strategies was that we would nurse patients outside in a tent. And then also that tent also was not well furnished in terms of oxygen and in terms of the basic necessities that are needed by someone who is a COVID-19 suspect. I would say though that we are not where we were when the pandemic started. I mean, there's so much of improvements that have been made in terms of infrastructure and in terms of human resources. Prof. Njali spoke earlier on about the nursing workforce, which was really, really worked on and was really improved by employing nurses. But in that regard also, there were a lot of challenges with the nursing workforce that was added, simply because a lot of these nurses that were added were number one, the first phase involved translation of staff nurses to professional nurses, those who had undergone bridging and were not in posts. So they were translated to professional nurses and they were put to deal specifically with COVID. Now, remember I said COVID was new to everyone. We didn't have any operational guidelines in terms of clinical praxis. And then you are taking an amateur who was a staff nurse and you are putting her in the middle or in the front line to deal with a new virus, which at that time were not clear about in terms of pathogenicity, in terms of treatment, and in terms of management of patients who already are confirmed cases or are suspected cases who are presenting with all these symptoms. So in that regard, I feel the department did not plan well. And I think had there been stakeholder engagement with people who were at a lower level, I think those things would have come off, would have come out and could have been included. So going forward, I think in the event of a new pandemic, that is something that they need to talk about, that you cannot put new labor, people who have not practiced clinically, people who have not been in senior clinical positions in the front line of a pandemic, especially when there is no information. And then in addition to that, that's just speaking to the poor preparation in terms of disaster management and the response of the Department of Health to the COVID-19 pandemic. So not only was the issue of staffing, but it was also with infrastructure, as I mentioned, with guidelines and with communication. When guidelines did eventually come, I think they were not clear in terms of healthcare workers and how they should be managed in the context of the primary healthcare setting, and in general as healthcare workers, how they should be managed in terms of the leave that they should sign and the quarantine and the isolation. So all those things were challenges. And I think even though we've gotten better with them, but from the onset, if that was addressed, I think you would have prevented a lot of problems, because in facilities that I know and the facilities that I'm working in, there was a lot of strikes and there was a lot of quarrels amongst amongst management and clinical staff, simply because there was no operational guidance from the start that deals with healthcare workers and how they should be managed. So that was a gap in that regard. And then also, as I mentioned, the fear was there and continued to be there, and was exacerbated even more by the lack of personal protective equipment, especially during the initial parts of the pandemic. At the moment, we have severely improved in terms of PPE. We are not where we should be, because, I mean, like, we are still signing for a surgical mask that we wear the entire day. So we are not there as yet, but I mean, it's better, because before we're forced to wear at least maybe one N95 mask for like 3 to 4 days. But now at least we have a surgical mask, but it's only one per day per professional nurse. So I think like there are still those challenges that continue to happen. And then with just to go back, I'm so sorry I'm jumping, but I'm trying to just share everything. But also with the guidelines as well, when they did come, as I said, there were a lot of discrepancies and they were not suited for the primary healthcare context. The guidelines were mainly clinically oriented and were for someone who was in a hospital setting. So someone who is in a PHC setting, it was not really user-friendly. So in that regard, you sort of had to use your discretion in a lot of the things, and you were not sure that you are doing the right thing at the same time. And also with relation to clinical management, I think the issue of infrastructure still needs to be dealt with at the moment as well. Because as I said previously, the facilities that we are in right now are not geared up for curative or curative care. It was mainly for treatment of minor ailments and for health promotion and disease prevention. I think right now the COVID-19 pandemic is really forcing us to and forcing stakeholders to go back to the drawing board in terms of primary health care. And because, it's forcing us to go back to the drawing board to sort of make sure that all the resources that are needed to function are there. Because I think primary healthcare is the entry point. And also, from what I know, primary healthcare does not only include promotive and preventive care, but it also includes curative and rehabilitative care. So for it to be complete, all these things need to be there. It's like, it's important that all the lessons learned from the COVID-19 pandemic and all the infrastructure that is demanded by the COVID-19 pandemic be put in place, because increasingly more people are using primary healthcare services. To go forward, I'm just reading here. And then also there was the issue now among staff was that because they were not prepared to deal with the COVID-19 pandemic, most staff did not want to deal with a patient who is, or a suspected case. And that's going back to the fact that they were poorly prepared for the pandemic. And then, so as a result also, the staff that did eventually go and nurse those patients faced a lot of, I being one of them, faced a lot of stigma from not only the community, but also from other healthcare workers who did not want to associate with you by mere fact that you had contact with a suspected case or a confirmed case. So it's all going back to the preparation. So just to wrap up, I think the major stumbling block to delivery of quality healthcare within the primary healthcare context was the poor preparation by government in terms of infrastructure, in terms of operational guidance for a nurse who's working within the primary healthcare setting. And also when it came to staff who had COVID-19 and who were suspected COVID-19, there was no clear guidance on how they should be managed. So I really would appeal to researchers that I think in this era, we need answers or solutions, research solutions that are going to talk to the practicality. Because as much as, like the guidelines were, especially in terms of mental health also, the guidelines mentioned that, provide mental health support to the healthcare workers and to the patients who are affected by COVID-19, but the how part was lacking. So for me, it's about the nitty-gritty, the actual working. So we need research solutions that are going to address the everyday workings, especially in relation to infrastructure and the day-to-day working. If I had to make an example, like where I work right now, we only had 2 oxygen points. And then you have maybe 4 patients who are having difficulty breathing, and you have 2 oxygen points. So now there, yes, we have been trained on how to triage and how to assess a patient, but then this patient is coming with a family member. What do you say to a family member who is waiting in the queue to get oxygen while you are only able to provide oxygen for 2 people? What do I say to the other 2 people who are waiting? So it's about those things. So I really would hope that from this discussion that we will get practical answers, because I feel like there's a lot of models on how care should be rendered, but they are not specific to the current context that we are in right now. At the moment, as I said, most of our facilities are not suitable to allow one for social distancing, and also they are not suitable for this current pandemic. So how do we work now to make sure that the facilities are provided with the resources? Because as I said, this is the entry point of services in the national health system. Thank you.
Thank you, Dr. Themba Nxumalo. Thank you. Wow, that was quite a long one, Doc, but you've shared all the challenges and the lessons learned during the time of when we were in the middle of the pandemic. We've learned a lot from your presentation, especially the infrastructure and the workforce related challenges. Thank you, Doc. Before we call on the next speaker, we would love to acknowledge the presence of our Dean on Teaching and Learning, Professor Sneko Kutuma, who is our College Dean of Teaching and Learning. Thank you, Prof. Duma, for blessing us with your presence in this webinar. Ladies and gentlemen, we've learned about the experiences of being a frontline worker in the PHC setting. We would like to move on with the program and hear from other frontline workers, but this time from the critical care side. And we would like to welcome Messi Zambezi, who is a postgraduate critical care student. Messi, over to you.
Okay, good afternoon, everyone. As you have heard, my name is Mesa. I work in the critical care area specialty. So I'm going to speak on the impact of COVID-19 on the nursing staff, as well as the students that are working in the front line, specifically with in critical care areas. Can I have the first slide? So the impact on the nursing staff, nurses were banished by the society as COVID carriers. We felt like we alienated, getting to the point where people could easily just disperse as you approach them, even close members that you think they would support you during the pandemic. They didn't want anything to be associated with you or to be closer to you. So this was one of the most difficult situations that nurses working in the frontline faced. There was also fear to infect loved ones, as well as being infected, as due to long working hours, nurses ended up being infected, as well as passing the infection to their family members. And some even lost their loved ones after getting infected from work. Next slide. There was also lack of staff. Generally, before the pandemic, there was shortage of nurses worldwide, it's known, but the COVID pandemic made it worse. And this came with added responsibilities to the few nurses that were working in the critical care areas. And as you know, there's so much of demand in the critical care areas, their responsibility, there'll be more. And working there also, irregardless of whatever nurses were doing, there was no allowances or any salary increase or any incentives, which was quite a difficult situation. Nurses also were working in the critical care areas or as frontliners. They also suffered nutritional problems as they couldn't take their normal tea breaks as scheduled because of the workload, as well as the type of patient that we're looking after. Their tea breaks, their lunch breaks were also affected. It was also due to poor appetite, or as you know that if you are exhausted, your eating patterns also get disturbed. So their nutritional status, they were also affected. There was also post-traumatic distress syndrome, which was caused by watching patients die in numbers, as well as losing co-workers and also family members due to the COVID infection. Next slide. Can I have the next slide? Next slide, please.
I'm with you, Messi. I think there's a
Alright.
problem on my side.
All right.
My computer, it freezes.
Okay.
Excuse me, ladies and gentlemen. Okay, there we are. So we are here, Messi. Sorry
Yes.
about that.
All right. Oh, as because of the COVID-19, you can remember the long hours that work, the 12 hours that you spend in your PPEs. It's your mask, it's your visor, it's your gown, your gloves. So this outrageous time spent wearing PPEs on its own, it was quite a challenge also because it was a new thing. We were used to working freely, and all of a sudden you need to mask up, you need to don, you need to doff. So at times, because of the shortage of PPEs, your donning and doffing times, maybe we're supposed to push for the next 6 hours without taking off your PPEs, because initially PPEs were in short supply. So working for 6 hours without taking a break, it was quite difficult for the nurses also. And the worst part that happened when somebody gets COVID-19 while he's working, where you get so much of questioning from the superiors about whether you were using the PPEs properly, how did you get infected, who were you sitting next to, what time did you take your tea break? All this also, it had impact on nurses working in the front line, like you get infected and people now want to know why and how you got infected. As mentioned with the previous speakers, that being stigmatized with the co-workers, it happened across the board, and people just want to be associated with you when you're working in the COVID-19 units. People will try to avoid you as much as possible, be it in the tea lounge, be it in the corridors, be it in the lift. So emotionally, it's something that was so draining on the nurses working in the COVID units. And to make matters worse, some nurses had to be medically boarded due to complications of COVID-19, and they are the breadwinners because they were incapacitated to work. So those are some of the impacts of COVID-19 on the nursing staff. And at the next slide. So I'm going to look also on the impact of COVID-19 on the nursing students, because we work with them in the units as well. So the nursing student, most of them, their studies has to be put on hold. And this had a financial impact on the students because some of them live in rented accommodation and they are self-funded to their education. So if your studies were put on hold, as it was explained previously by Dr. Jarvis, that student had to take a break, which means there was a delay in achieving your qualification, and all this had also an impact on the students. And some of them were breadwinners who were wishing to complete their studies and start working, but exam dates had to be extended. So you can imagine the financial impact, the psychological strain that comes into play. Also, there were no contact classes or lectures, resulting in online classes, which have their own drawbacks depending on be it the network, be it the gadget we have. Also other challenges, including load shedding and the data costs that run in care. So even the online classes, though they helped them, but there were so many challenges faced with the online classes. May I have the next slide?
I'm trying, but it takes time with this computer.
All right, that's fine.
Oh my goodness. There we are.
Okay. So students also missed out on classes and group discussions, which also plays a vital part, as I'm also a student, I'm still working, learning. So group discussions and classes, they play a vital part during the learning process. So missing out on those ones also impacted on the final results on the students working. And also because of the COVID-19, there was shortage of staff and students were being used as a workforce to cover for staff shortages. And most of the time they didn't meet their course objectives. They also had to neglect the theory part of their studies due to suspended classes. And much of the input, even though you still get it clinically, but you also need the theory input so that you can apply what you have learned in class to what you are seeing in the clinical area. So if you miss out on the theory part, at times one won't be able to marry or to try to find out what's happening in the theory and what's there in the practical. And students also didn't have proper practical assessment due to the pandemic, especially those ones that were placed in some units that were closed completely, because there was a time when all the selective surgeries and other units has to be closed to cater for the increased number of COVID patients. So some places that they were supposed to be in to gain their practical experience as well as have assessments done, they couldn't do that because of the lockdown restrictions. Can I have the next slide? Okay, even though we had faced all these challenges, we still soldiered on and uphold the noble profession of, and our light is still shining on. So we just think that even regardless of all the challenges that we have faced as nurses working in the critical care area, we have tried to work so hard to try and implement all the necessary precautions, even with the hardest achievements, with the hardest challenges that we have faced. So we still keep working hard, but it's getting better with time, with the experience that we have had from the first wave to the second wave. Now we are in the third wave, we're more prepared, we are so calm, we know that things happen, and we thank you for everything. Thank you for listening.
Hey,
Thank you, Dr. Mhlongo.
Thank you, Misty. Thank you so much for a well-prepared presentation. And I would just like to apologize for my laptop that is having hiccups. But thank you for a well-coordinated presentation. Ladies and gentlemen, that was the experience or the lessons learned from the critical care side. We would now like to continue and have another frontline worker, but now we're going to hear the experiences of a fourth-year student, a Bachelor of Nursing fourth-year student, also sharing the experiences of being a frontline worker in the midst of the pandemic. Let's try and see if Sibosile can see this presentation.
Yes, Doctor.
Thank you.
Good afternoon, everyone. I'm student nurse Sibusile Ngumalo, and I'll be presenting the impact of COVID-19 had on us as nursing students. Can I have the next slide? The year 2020 was a challenging and very emotional year that required all of us as students to quickly adapt, condition our minds, and to adjust to the changes that were being made. When the first case of COVID-19 was confirmed in March 2020, we all had, we were just at the beginning of our third year. We were doing our practicals in hospitals all around Durban. So when the virus started spreading to our country in 2020, the Vice Chancellor had to announce the closure of the university and had to send us home on that week. I think it was the 17th of March. Can I have the next slide, Doctor? So as the nursing students, we were very, very worried and anxious about the South African Nursing Council, which is the SANC hours that we must comply to. And therefore, we became stressed, anxious, and started to question our lecturers about the large number of outstanding hours that we had to complete. For example, skills laboratory competencies, and whether we would be able to complete the hours and to finish in due time our degree. It was overwhelming to us. We even thought of refusing to go home and write to the Vice Chancellor and request to continue with our studies. It was very heartbreaking and stressful for us to pack our bags and go home. not practice, as we knew that it would have a great impact on our ability to complete our studies on time and to gain greater knowledge. Doctor, can I have the next slide? So while we were stressing and worrying about the sudden interruption, we were introduced to the online learning in order to push theory when COVID-19 settled. We will have time to focus more on theory. To focus more on doing practicals. The remote online learning added to our stress levels as we did not know how to access it. We were struggling to cope and adjust to the changes because some of us live in rural areas. For example, I live in Msinga, where there is poor network connection. We would run out of data while attending Zoom classes, and some of the students left their laptops for repairs and maintenance at campus. So it was a great struggle to us and to our lecturers. Can I have the next slide, Doctor? So the challenges of studying while at home, although the National Student Funding Aid Schemes, which is NSFAS, was still providing for us, most of us used that money to help at home as the country was still at level 5. So we didn't have money, or we didn't have change to buy data or to buy airtime to contact others to ask what is happening in class. So only there were only essential services staff were permitted to work, and unfortunately, most of our parents hold jobs that are considered non-essential. For example, domestic workers, they are waiters, they are street vendors. So we had to assist. So most of the funding received from NSFAS went towards household expenses. About 30% of the students could not stay for long periods of time in Zoom class or attend in the morning because our parents did not understand the online learning. They would ask us to go buy bread or do some house chores and then attend the class. They didn't have the understanding of what is literally going on. While trying to focus in class, one would get disturbed by the noise. For example, my mom usually plays the radio the whole day, and my home is near the road. Therefore, I would get disturbed by the noise and children playing in and outside the house. So I couldn't concentrate and I couldn't participate fully in class. In rural areas where I stay, when there is bad weather, there will be bad network connection. I can't see the last part clearly. Doctor, can you please move on to the next slide? So the return to campus and clinical settings, when we were informed that we have to return to campus, it was June 3. Yeah, we were scared and frightened that we would get COVID-19 as the numbers were still fluctuating. We were, however, relieved that we were called back to carry on with our degree and that we will finish on record time as our lecturers have pushed the theory parts of our third year. We were scared for our lives when we were told that we would be going back to the clinical setting. We were given a face shield and a mask, not full PPE and surgical masks, but they were not sufficient. In some of the clinical settings, we were told that the hospital does not give PPE to students. It was only provided to the staff, hospital staff only. But that we had second thoughts about continuing with doing practicals, but we had no choice but to make and to make sure with what was available at that time. In the clinical settings, the wards were short-staffed as a majority of the staff had to go for quarantine. We were not getting much time to learn from the professionals. Doctor, cannot see the last sentence. So we couldn't quarantine. We were challenged to work, do what we were competent at, and what was in our scope of practice as students. And at that time, we had to observe and learn through practice. The focus shifted from learning as a priority to responding to COVID-19 challenges and the shortage of staff. But we were at the same time glad to help in the time of the crisis. I remember in the surgical unit where I was working at, we had to dress a patient daily with only 2 surgical masks. If I remember correctly, we were only given 2 masks a day. The patient had burns on his chest and neck. 2 days later, we learned that he tested positive for COVID-19, of which was a great shock to us, because we were in direct contact with the patient, and we only had mask on. We couldn't quarantine because the staff was short, and there were no more staff who would take over from us in the surgical ward. Next slide, please. In December 2020, during the second wave, there was an outbreak because I was working in the theater. There was an outbreak at the theater. Therefore, I tested positive for COVID-19 while I was working in the surgical theater. During that time, 2 students from UKZN also tested positive for COVID-19. It was a great shock to us. We did not want to tell our parents because they would shout at us and they didn't understand of what was going on. And unfortunately, somehow we were tired of explaining to them. And our lecturer, because we will have to quarantine and lose hours, but at the same time, we were scared of dying and infecting others. We eventually told Sister Jane, who is our occupational health nurse and our lecturer, our 3rd-year lecturer. And then I realized that in the midst of it all, being a nurse means putting your life at risk for the patient to get help. And I got an opportunity to understand better the part of the nurse's pledge that says patients are our first priority. In conclusion, again, in the midst of it all, COVID-19 gave us firsthand experience of what it means to be a nurse. It taught us to be strong, to sacrifice, to think for our patients who need us more, as we will soon be sisters in charge. It taught us to persevere and, sorry, doctor, I cannot see the last sentence. And hope for the best. Indeed, we managed to complete our hours and our 3rd year. Can I have the next slide, Doctor? Thank you so much for listening. Thank you, Dr. Mhlongo, for the opportunity.
Thank you, Sibusile. And I would also like to apologize from you. The computer just freezes anytime. But thank you for making time and for a very practical presentation of sharing your lived experiences of working as a student, a 4th-year student in the midst of the pandemic. Thank you so much, Ms. Nomalo.
Thank you, Doctor.
Yeah, ladies and gentlemen, we are towards the end of our webinar. I would like to open this platform and get a question or two from our audience before we move on. Just a question or two. We've been listening to speakers sharing so much information. You can either raise your hand, Professor Petra, Bryce Vids will be monitoring hands, or you can put a question on the chat. Petra is monitoring that. The platform is for you, ladies and gentlemen. In the interest of time, can we ask 2 to 3 questions and continue? Prof. Brasovitz will indicate if there are hands.
There is one question. I'm going to allow the person to talk. Would you like to go ahead? Rita? You need to unmute your mic and you're welcome to talk.
Rita, can you please unmute and ask the question? Maybe Prof. Brasovitz, you can take another one if there is, while Rita is still working on hers.
There's a question in the chat, and the question was, and it's to whoever feels they'd like to answer, what was and what is the role of the South African Nursing Council during the pandemic?
Thank you for that question. I won't direct the question directly to the speakers. Anyone, as Prof. Petra has said, even our senior staff members can answer. Thank you, Prof. Mchali.
Am I supposed to respond to the question about the role of the Nursing Council?
Please, Prof. Mchali, if you can.
Okay, we have our seniors here from the Nursing Council who may answer this question better, but I would just answer from what I know. Earlier on, I indicated that in the process of recruiting additional nurses and midwives, then those nurses were no longer part of the register. So the Nursing Council, then the Department of Health had to approach the Nursing Council and work on how these nurses can be supported. So the nurses then resolved not to make these nurses pay the restoration fee, which was in some way a way of then saying, how can we contribute towards the responding to the pandemic? And then secondly, the Nursing Council also, to make life easier for us financially, then the Nursing Council has indicated that the 2020-2021 subscription, there won't be any increase. So that is what I know the Nursing Council did. And then now and again, they were sending statements of support to us as nurses in the field. If you go to the website, you'll see that there were statements which were then just encouraging nurses and appreciating the contribution of nurses. Thank you very much.
Thank you, Professor Mchali. Well answered. Prof. Brasovitz, any other questions?
If I can just, I'm going to just go to a comment from Jane Taylor, and then we'll come back to Rita. So Jane was just saying, well done to all the speakers. I do not think the general public are aware of the traumas experienced by the healthcare workers, by the frontline workers. And she just wanted to say thank you to all those workers. And I'm sure a lot of us will all echo those words. Rita, would you like to unmute and ask your question?
I've unmuted now, Doctor. I've unmuted now.
Right, please go
ahead.
Okay, thank you, Doctor. You know what? Thank you very much. I'm sorry, I've joined the meeting, the workshop already a bit late. I was having a problem with my laptop. I joined when Themba Nxumalo was speaking. So thank you very much for arranging this beautiful workshop that are enlightening us. But there's only one thing that I want to ask Dr. Generally, that if our frontline nurses, the volunteers and it's good anyway, because our first consideration is the patient. But what does the government does as far as compensation of these employees? I understand that one of my colleagues got infected, but I just heard that the compensation that they get is only 7,000 rand. Imagine a breadwinner losing his or her life, leaving kids, leaving everybody. So now they will just get a lousy 7,000 rand. So and another big impact that we've experienced, I'm working at CJM Nursing Campus, is this extension of training. So it causes a lot of trauma to students. So I'm so much concerned, Doctor, about the compensation of these people who are frontline workers as far as the COVID-19. Thank you, Doctor.
Thank you, Rita. And again, I don't think the question is directly is directed to the speakers that has presented. I just think that any senior member in the webinar can maybe respond to Rita's question regarding compensation of staff during COVID-19. Any member who is senior than us who can try and attempt that one? Thank you, Prof.
I think maybe the question is outside our scope, but what we can do is then to present the matter to some of our structures that are working with the Department of Health, so that at least we have more information and see how then the matter can be taken forward. But as an academic institution, I think it's outside our scope. But the point raised by Rita is very, very important and critical. Because I was just reading from some of the countries, like in Ghana, there were some incentives that were in addition to those who get infected due to COVID-19. So maybe we are not aware of the information that is available in the country, hence the need for us to explore further this before we respond.
Thank you, Professor Mchali, for raising that. Thank you so much. Prof. Petra?
I have one last question here. It was just in the chat, and it says the person is asking if UKZN is still teaching management of disaster planning. It's not directed to anybody. Again, if anybody can answer.
Are we still teaching disaster planning at UKZN?
It's taught as part of the courses, not as a standalone module or as a standalone program. But it may be part of it may be part of the short courses, maybe that may be offered by the college, because we are experiencing a number of disasters, from climate change to health emergencies. So I think it's one of the short courses that we'll have to work on, but we have to determine the need working with the Department of Health, because we are training for the Department of Health. But if the need is there, then we have a mechanism to ensure that at least our nurses are prepared for disasters and for emergencies, health emergencies.
Thank you, Professor Mchali. Before we conclude our webinar, Prof. Petra, is there anything you want to read from the chats, which is of importance?
I think that they are just messages of congratulations to the speakers, etc. So I think we can continue. Thanks, Mbali.
Thanks. I think there is another from Professor Toma, another message from Prof. Toma.
Yes, it's just reinforcing what Fikile was saying around the role of the South African Nursing Council.
Okay, thank you so much.
And then just one point from the side of the Nursing Council as well, in terms of education and training, they also provided guidelines on how to manage teaching and learning during the emergencies, and then also the flexibility in terms of meeting the clinical requirements and the utilization of the clinical skills laboratory as part of clinical training. So the Nursing Council really did a lot in terms of then education because we are in the education sector. I cannot talk about practice, but in terms of education, they did a lot for us to provide the tools and the guidelines for us to manage and navigate the space, teaching and learning space during the pandemic. Thank you.
Thank you, Professor Mchali. Without the waste of time, I would like to thank our speakers who have presented and who have shared with us their experiences as frontline workers. And I would like to take this opportunity and welcome Mrs. Sosibo and hand over to her to give us the concluding remarks. Mrs. Sosibo is the Director of Nursing Services in the province. Thank you, Mrs. Sosibo. Mrs. Sosibo, please unmute yourself and take over the platform, ma'am. Mrs. Sosibo, I can see her, but she's muted. Mrs. Sosibo, please unmute yourself and carry on. Thank you, ma'am.
Yes.
Over to you.
Yes, Mrs. Sosibo is not around. Let me go call her. No, she has just left the office, and maybe she went to the toilet. Okay, let me go call her. Mrs. Sosibo.
Let us give Mrs. Sosibo 2 minutes. Apparently, she is still with us, but she went to the ladies. That's what the speaker is saying here. Just 2 minutes for Mrs. Sosibo.
Hello?
Yes, ma'am.
Hello?
Yes, ma'am, we can hear you. Mrs. Sosibo?
Yes, I can hear you.
Okay, ma'am. We would like to give this time to you. You can carry on and give us the concluding remarks.
Oh, thank you very much, Doc. Thank you very much. I'm sorry for that. I had to quickly go out for a few minutes. But firstly, I would like to
Mrs. Sosibo?
take this opportunity.
Mrs. Sosibo, I'm not sure whether the audience can hear you. I can hardly hear you.
I can hear you.
We can hear her.
Please continue, ma'am.
Okay, thank you very much. I just want to say thank you very much to eye-opener if you hear all these experiences from the students that we have been utilizing as the workforce, from the people that are like from the Dr. Nxumalo, who is working at a primary health care settings. You know, whatever they are saying, it's a true picture of what happened initially when we started experiencing COVID-19. It was not easy for anybody, but we had to put pieces together and go ahead and work. I must say I was very impressed about the student who quoted our pledge and who was able at this stage to realize the importance of being the nurse, to realize how the nurses sacrifice themselves. If we are saying that our profession is a selfless profession, it was our time as nurses for us to experience what is meant by that. I think it was quite a learning experience as they were going through, especially a primary healthcare setting, with Dr. Nxumalo, when he was talking about the nurses that were inexperienced but were expected to do the best out of nothing. And most of our nurses, I must say, not only the nurses, everybody was overwhelmed. There was anxiety as initially when we first experienced the first case, we knew what was coming. So I really appreciate that, and the researchers that have done quite a lot of work to make us aware of what has happened and what we need to improve moving forward. I highly appreciate the team and the speakers. Whatever they said, it was worth it. And again, going back to the students now, I know that they had to put their training on hold. The experiences where they were in the areas where they cannot access connectivity due to poor connectivity in rural areas. The basic example of the children that are making noises meanwhile you are trying to focus on your studies. It's really an eye-opener. We really highly appreciate that. Thank you very much, Doctor. Thanks.
Oh, thank you so much, ma'am, for making an effort and give those concluding remarks into this webinar. And we appreciate the time well spent with us. As we close our webinar, I would like to call upon Prof. Petra Brasevitz to give a word or two. Thanks, Prof.
Thanks, Mbali. Just to say thank you very much to our speakers, and as the members of the panel and audience have said, it's been really interesting to hear this experience both from the clinical nurses side as well as our students, and thank you very much for highlighting that. We have really heard about how nurses had to sort of think on their feet, how they were made to face stigma, and as Mercy had said, being viewed as COVID carriers, and what that then meant for how they were treated at work and how they were treated in the community. We heard again about the difficulties that nurses experienced in terms of accessing PPE, having sufficient PPE, and then as Mercy pointed out to us, having to spend these excessive hours in PPE and just how difficult that has been. We heard about students being scared for their lives in knowing that they needed to go back to the clinical areas, but having this really difficult situation where they needed to be there in order to finish their studies. And then what this then required from them in terms of being able to make that happen. We heard, however, that there are some positives that have come from this in terms of lessons that we have learned and that we need to harness and use moving forward. We heard about making use of digital technology and how digital psychological first aid is perhaps something that is that we need to explore moving forward, and that we need to look at our public health nursing. And so I think in closing, it's just to say we need to take these lessons that we've learned and really use them to improve things in the future going forward, because as we keep hearing, we will be facing more pandemics in the years to come. But thank you very much for all your attention. And thank you for spending this afternoon with us to really explore this important issue. And take care, and goodbye from us. Thank you, everyone.
Thank you.
Thank you very much.
Thank you.
Bye.
Goodbye, everyone. Thank you.
Goodbye, Doctor.
Goodbye, Dr. Mhlongo.
Goodbye, Prof. Mchali. I'm so
Thank you very
impressed.
much for
Our
everything.
students were connected as well. I'm very impressed.
Yes, they've made us proud. Thank you very much. And thank you for organizing with Petra. Thank you.
Thank you, Prof.
Bye.
Bye.
I can end it now. All is good.